Good evening, everyone, and a very warm welcome to the final round of Case Off, an online case presentation competition by MSAI. I am Salman Khan. I'm currently serving as the Vice President for External Affairs at Medical Students Association of India for this term. In most clinical settings, case presentation is the most frequently used teaching and learning activity. From an educational viewpoint, the two important roles of case presentations are the presenter's reflective opportunity and the clinician educator's clues to help the presenter diagnose the case. With an aim to introduce to medical students the essentials required for case presentation in a clinical setting, the Standing Committee on Medical Education of MSAI has launched this case presentation competition. We received a huge number of abstract submissions, and upon screening, we finalized our top 9 this evening. Our judges for this evening are Dr. Sonal Saxena and Dr. Madhav Balakrishna Prabhu. Dr. Sonal Saxena is currently working as the Director, Professor, and Head of Department of Microbiology at Maulana Azad Medical College, New Delhi. She serves the following responsibilities, which include state-level VRDL at ICMR, Nodal Officer at COVID-19 Laboratory at MAMC, Lab Coordinator for Delhi's COVID-19 Zero Survey, and Joint Secretary for Indian Association of Medical Microbiology. Her special interests include antimicrobial susceptibility testing, antimicrobial stewardship, bacteriology and infectious diseases, and medical education. She has received the R.A. Bhujwala Award for contribution to medical microbiology at IAM Delhi Chapter 2020, and she completed her WHO fellowship on antimicrobial resistance at ICHAR Karolinska Institute at Stockholm, Sweden. She has contributed to around 5 books and chapters and 60 articles and has been cited more than 300 times. It's a pleasure to have you with us, ma'am. Our second judge for today is Dr. Madhav Balakrishna Prabhu. He is the Associate Professor at Department of Medicine at Jawaharlal Nehru Medical College, Belagavi. His area of specialization are diabetes, tropical diseases, and HIV. He has contributed to more than 20 paper presentations at national and international levels, engaged in 3 research activities, 2 original articles published in peer-reviewed journals. He has 2 chapters in textbooks published and has received 6 awards for immense work in his current field. He is also a member of various eminent professional organizations. Thank you so much, both of you, for taking out your valuable time from your busy schedule and being there with us this evening. Without any further ado, I'll hand over the floor to Arpita Saxena, who is one of the national officers in medical education.
Good evening, everyone, to everyone present here. First of all, I would like to thank Dr. Sonal and Dr. Madhav Prabhu sir for joining us today here. Without any further ado, I would like to orient our participants to the rules for the competition. Each participant will have exactly 3 minutes to present their presentation. The screen will be shared by us, and please say the words. Please say next slide whenever you want to change the slide. On 3 minutes, I will announce that 3 minutes are up. Following that, the judges will get time to pose their questions, and for that, you will have 2 minutes to answer the questions. The judging criteria is based on format of case presentation, creativity, difficult level, approach to patient, and presentation skills and language. If there are any questions, please do let us know right now. If not, we can start ahead. Shritika, would you like to share the screen? The order will be announced. The order for the presentation will be announced as in how the screen is shared, and the presentations are started. So please keep an eye. And the participants are requested to not leave the Zoom call till the end, as the results will be announced at the end of this call today only.
Is the screen
starting
visible?
with the yes, it's visible. Ria, do we have you here with us? Ria, you are not audible to us. Mm,
I think Ria has to unmute herself.
yes. So she's unmuted, but I think she might be having some internet issues.
I think we can move to the next presentation so that we don't waste
Yeah.
time. And meanwhile, Ria can log out and log in again.
Yes.
Maybe that will permit it.
Yes. So for our next presentation. Okay.
Hello.
Yes, you're audible.
Can I switch on my video as well?
Yeah, sure. Perfect.
Okay. So I will start now. Good
Yes.
evening, everyone. I am Shuchi Abhishek, an undergraduate student studying MBBS at Kasturba Medical College, Manipal. And today I present to you a rare case of an unusual, invisible, traumatic head injury with isolated full-blown pupil. Next slide. Introduction. So oculomotor nerve palsy is following a mild head injury is something very rare. And because the trauma required to damage the nerve is usually very severe and is associated with basilar skull fracture or neurological deficits like loss of consciousness. The recovery rate following complete ONP is prolonged and it often results in incomplete resolution. So through this case, we describe a patient who developed isolated right-sided oculomotor nerve palsy following a mild closed head trauma, which we describe with a GCS score of 15. And a peculiar feature was the lack of association between the MRI findings and clinical manifestations that gave us an insight into the mechanism of injury to the nerve. Next slide. So case report, a previously healthy 24-year-old male rider came after a bike crash. And his main symptoms were diminution of vision, inability to open his right eye, and diplopia. He denied loss of consciousness, nose bleeding, vomiting, or seizures. Next slide. At presentation, he was conscious with a GCS score of 15. His vitals were within normal limits, and initial neurological examination revealed that he was cooperative and well-oriented. Next slide. So on examination of the right eye, there was ptosis, lateral deviation of the eyeball, and a fixed and dilated non-reactive pupil measuring 7 millimeters. He was unable to move the right eyeball, and the rest of the examinations were normal. The left eye had no limitation in extraocular movements, and the pupil was 2 millimeters and reactive. All other neurological exams, cranial nerve exams revealed normal findings. Next slide. So this picture is a picture of our patient displayed after a written informed consent. Figure A shows ptosis. Figure B shows a fully blown out dilated pupil, classically described in third nerve palsy. And figure C shows the intact pupillary light reflex. Next slide, please. Investigations, well, CT had no evidence of trauma-related injury, and MRI revealed some findings, which I will show in the next slide. So figure A and B are CT images, which do not have any significant findings, whereas on the images C and D, which are MRI images, there were a small hemorrhagic contusions, which did not likely have any.
Your time is up.
I just want to point out that when I'm not having the control of the slides, I think I'm missing out a bit of time. So could I just show the rest of the slides?
We can just run through them once. Shrutika, can you just run through the slides once?
Okay. Could you just a bit slowly?
Yeah. This next slide.
So that someone could at least read it, please.
Next slide. Next slide. Okay. Dr. Madhav Prabhu sir and Dr. Sonal ma'am, are there any questions for the presenter?
Yeah, I think ma'am should go first and then I can come in.
Actually, first of all, Suchi, many congratulations for doing some research work and some interesting case presentations in your undergraduate itself. That's very encouraging and a very nice sign that you people are working so hard on besides your curriculum. One thing I would like, can somebody please focus on slide 12? Yeah, you know, when you have a presentation for 3 minutes, my suggestion, Suchi, to you would be to keep your slides like this. This is my only comment. The technical comments will be given by Dr. Madhav Prabhu, but you should just have an image and a few words to describe that image. And similarly, when you are presenting these cases for your, you know, examinations or ward leavings or end postings or whatever you call them, you should have a very crystal clear, precise information that you want to give to the examiner. Right, sir?
Absolutely. And you should practice this thing again and again, maybe because of the slide thing, a little time here and there, but you have to figure out all these things and then you have to do the presentation. A few things that I would like to question you is, can you tell me what are the usual findings of a case with head injury, pupillary findings?
So any specific head injury? Well, I would say that
okay, let me be more specific.
Okay.
Let's say that there is a head injury and there is increased intracranial stress or pressure. So what are the pupillary signs that you look for?
So usually there's something called as Hutchinson's pupil, which is usually initially there's ipsilateral meiosis followed by dilatation of the pupil, which indicates raised intracranial pressure. And if the pressure is not relieved, or if there is a cause that is causing the pressure to keep rising, then the similar findings will present in the opposite eye as well. So through my case, I wanted to highlight that usually finding a dilated, blown out pupil in the emergency department after a head injury is always associated with a grave prognosis. However, through our case, we want to highlight that
so the other thing could be a raised intracranial pressure, right? If there is unilateral dilatation. So how will you differentiate what are the other signs of raised intracranial pressure when you have such a case? So that those signs are not there, you can think of what you were thinking in your case.
So there were no neurological deficits. A raised intracranial pressure can cause brain herniation. There was no vomiting. There was no headache. There was no blurring of vision. I mean, like from the other eye, it was.
These are symptoms. I'm asking you signs.
Unilateral blurring of vision. So, yes, sir. I'm sorry.
These are symptoms. I am asking you signs. What are the signs of raised intracranial pressure?
I think we can move to the next presentation now.
Yeah, I think we can move to the next thing. Right. Thank you.
Thank you. Thank you.
Good presentation. Good presentation. Nice case.
Thank you so much.
Thank you for that. So moving on to the next presentation. Also, everyone, due to technical issues, we will be sharing the screen for all the presentations. I would just like to point out that maybe you can run a little faster with the presentation so that you don't run out of time for that. So yeah. Okay. Jeffy, do we have you with us?
Yeah, let's start.
Okay. Whenever you're ready.
Yeah. Good evening. I'm presenting a case on biliary atresia, ileal atresia, and shortcut for its rare entity and innovative management. Next slide, please. Next, incidence of intestinal atresia 0.025%. In association with shortcut, 17.5%. Incidence of biliary atresia 0.01%. In association with small bowel atresia, 3.2%. 2 cases have been reported in literature so far where shortcut is associated with biliary atresia. Next slide. A primary doctor was referred with an antenatal diagnosis of ileal atresia at 30 weeks of gestation. Ultrasound showed bowel dilatation. Next slide. At 32 weeks of gestation, there was increasing dilatation of bowel and increasing polyhydramnios. Maternal steroids were given, and at 35 weeks of gestation, the baby was delivered. Next slide. Operative findings included a dilated small bowel with ileal atresia and a 2x3 cystic mass, which is 2 centimeters away from the ileocecal junction. End-to-side ileocolic anastomosis was done. Next slide, please. The baby was put on TPN and there was failure to gain weight. A diagnosis of TPN-induced cholestasis, cystic fibrosis, insatiate bile syndrome, and biliary atresia was entertained. Next slide. HITA scan was done and the baby was posted for Kasai's photoultrasound. Next slide. The inadequate length of the bowel owing to Kasai's to shortcut syndrome was circumvented by doing a Kasai's photoultrasound with stomach tube interposition. Next slide. These are the intraoperative images. Next slide. Post-op, the bilirubin levels came down. Next slide. Summary: neonate, small bowel atresia, short bowel, neonatal cholestasis, biliary atresia, stomach tube interposition done. Next slide. A very interesting study done by Zeratin et al. Shows the association of biliary atresia with small bowel atresia and short bowel syndrome. In that experience, the appendix had been used. Next slide. Since in our case, the appendix had already been used, a novel technique of biliary reconstruction using an isolated gastric tube was done. This has been done in one adult patient and in dogs, and autopsy showed satisfactory results. Next slide. Stomach tube interposition helped in solving the problem of short bowel in our patient. The jaundice is coming down, but it is too early to state whether it is successful. To prevent cholangitis, where an isolated stomach tube could help, needs further assessment. Next slide. These are my references. Next slide. Thank you.
Thank you so much for that. Moving on to the judges' questions. Sir and ma'am.
Yeah, that's a very interesting case, Jeffy, and well done. Where are you from?
I'm from Coimbatore, ma'am, Tamil Nadu.
And which year? Final year.
Final year, yes, ma'am.
Final year. It's a little complicated case for a final year, I believe.
Yes, ma'am.
You should stick to simpler things in life to make life easier, no?
Okay, ma'am. Yes.
Yeah, anyway, but what are the causes of biliary atresia otherwise in such children?
Ma'am, and necrotizing enterocolitis is the most common cause, and then it could be due to like other causes of intestinal atresia, like duodenal. It could be associated with duodenal atresia and colonic atresia as well.
Okay, okay, from my side. So.
What were the anticipated complications that the baby would undergo if not operated? And after the surgery, what do you think would be the problem with this baby?
The anticipated problems include liver failure and ascending cholangitis, and we do anticipate, I mean, the most common one is ascending cholangitis, so we do anticipate that in this patient post-operatively.
That's fair enough. Good presentation, good case. You should be a little more, when you're presenting something, you know, you are teaching something to somebody. So you have to practice this again and again so that you are there. Okay?
Yes, sir.
Right.
Thank you, sir.
Right. Thank you so much for that. Moving on to the next presentation. Hi, Simran, do we have you with us?
Hello. Yeah.
Yes. We'll start whenever you're ready.
Yeah. So
Yes.
I'm Simran. I'm an MBBS intern from JNMC Medical College, and I'm presenting an unusual presentation of cutaneous TB. Next. So skin is the rare side of TB, and it consists of 1.5% of extrapulmonary TB. And in our case, we have endogenous cutaneous TB, scropholoderma, and tuberculosis, which are hypersensitivity reactions, lichen scropholosorum. Next. So here is a 22-year-old female with chief complaint of swelling over neck, chest, and axilla, which started draining during the last 6 months. Also, this patient has a history of reddish lesions or over her abdomen, which were associated with pruritus. Next. Next. On examination, as you guys can see, there are several puckered scars over her chest area and draining sinuses as well in the axilla as well as on the chest. There are also plaques and swellings present, and this is a typical scrofuloderma, which is an endogenous cutaneous TB. Next. On examination of the trunk, the abdomen and the back, you can see a perifollicular, around the follicles, reddish brown lesions, and these were associated with pruritus. They are present all over her abdomen as well as back. Next. On investigations, NAN2 test was positive. On aspiration of the neck abscess, you could see that it was ZN positive for AFP. Skin biopsy from the lesion showed that epithelioid cell granulomas with Langhans giant cells, which is consistent with scrofuloderma. Skin biopsy from the papules of the trunks, they showed that the epithelioid cell granulomas within the papillary dermis without any cacheation necrosis. These two types of presentation of the skin biopsies are consistent with our diagnosis of scrofuloderma and lichen scrofulosorum. Next. So for treatment, we started ATT, and after a month, there was improvement, but still the lesions were there. Next. So scrofuloderma, what it is, that it is basically an endogenous cutaneous TB which spreads from an underlying focus of tuberculosis. First, a nodule forms, then it increases in size, and then it ulcerates, and then it forms a fistula which drains caseous material. Next. Lichen scrofulosorum basically is a hypersensitivity reaction to Mycobacterium tuberculosis bacteria. And basically it is a manifestation of present or past systemic TB. It is 1 to 5 mm sized, and it is present on the trunk, and it is follicular or perifollicular reddish brown lesion. These lesions, they resolve by themselves or they resolved with ATT. Next. Why my case is important is because although we know that TB is present. Okay.
Okay, thank you for that. Sir and ma'am, questions, please.
Yes, I just have two questions for you. What are the degrees of such kind of skin lesions see in clinic? What would be should come to your mind?
Sorry, the audio is cracking.
I just want potentials for such a case of TB.
All right. I've even shown it in my slides that for scrofuloderma, which is kind of like an abscess, a cold abscess, the DDs are basically a bacterial abscess or some kind of tumor metastasis. It can be a histiocytosis as well. And for lichen scrofulosorum, my DDs I have shown it that it can be lichen spinulosus or lichen nitidus. Something like that. So
any other infectious agent, slow growing infection?
Slow growing. I am not. I don't know what's that.
Okay.
Yeah.
Infection. Yeah, but fungal infections to skin lesions which can get and appear just like. The thing is that contours would patient. What is the alternate to contour these? What should be done in such patients, or maybe diagnostic and more?
We can also do an interferon gamma release assay to see that if it is not a latent TB or a false positive test.
Right.
Yeah.
That's from my side. Sure.
Yeah. Is cutaneous tuberculosis primary tuberculosis or secondary tuberculosis?
It can be primary, sir. As in my patient, it is primary. The chest X-ray and the sputum analysis were negative. So in my patient, it is primary, but it can be secondary as well. Like lichen scrofulosaurum is basically a secondary kind of thing because it indicates a past systemic TB infection, but it can also happen primarily.
What are the other cutaneous lesions in tuberculosis?
So they can be some kind of chancre as well, a tuberculous chancre, or we can also see that there can be miliary TB, which is basically hematogenous disseminated TB, or we can.
I'm asking you cutaneous tuberculosis, different types of cutaneous tuberculosis.
Yes, sir. There are 4 types of cutaneous tuberculosis. Exogenous tuberculosis, which example is tuberculous chancre. Then endogenous tuberculosis, example scrofuloderma or hematogenic disseminated miliary TB. Or
how many months of ATT would you recommend in this patient?
Sir, normal ATT, because these lesions, they resolve by themselves, but with ATT, they have a faster course of resolve. They resolve faster with ATT.
How many days would you recommend? How many months would you recommend?
So the initiation phase of 2 months and 3 months, and then 6 months of maintenance phase.
3 months. Okay.
Sorry?
Fine.
Yeah. Thank you.
Thank you so much for that. Can we move on to the next presentation, please? Anusha, are you here with us? Anusha, you're on mute. Anusha, we can't hear you. Okay, I think we will move on to the next presentation in the meantime. Anusha, can you can you sort out your internet connection in the meantime? We will move on to the next presentation. Darshini, are you here with us? Yes, Anusha, no worries. Darshini, are you here with us?
Hello. Yeah.
Yes. Yeah.
Okay.
Yeah, whenever you're ready.
All right. A very good evening to everyone. I'll now present my case of a congenital adrenal hyperplasia in an 8-month-old infant in Ahmedabad. Next slide, please. So congenital adrenal hyperplasia is usually a group of autosomal recessive disorders, which are majorly of 3 types. And this involves in the deficiency of the synthesis of cortisol or aldosterone or both because of a deficiency of a key enzyme that is involved. Usually this is the most common type of CAH is due to 21 hydroxylase deficiency. Prenatal androgen exposure is also associated with it. My case will be my case is about an infant who presented rather late at 8 months than the expected 1 to 4 weeks of which is usually presented after 1 to 4 weeks of birth. And there was also an atypical presentation of seizure. Also, while female neonates have ambiguous genitalia, male neonates are usually born with normal genitalia. Next slide, please. So my case is about an 8-month-old male child who came presented to the ER with complaints of seizures and lethargy since the afternoon. The seizures were continuous in onset and they were generalized, and the child was afebrile. The mother's antenatal history was normal. She had a normal delivery. She had taken her iron folic acid tablets as well. The child was stabilized with anticonvulsants and fluids. Next slide, please. On further examination, a general examination showed dehydration, while physical examination was very important and showed ambiguous external genitalia with hyperpigmentation and slight rugae over what seemed to be labia majora in the kid. Past records of chromosomal karyotyping revealed presence of XY chromosome. USG revealed undescended testis. ABGA showed severe metabolic acidosis. CBC was normal, so there was no query of infection as such. Serum electrolytes was what was found to be very shocking, as it was severely altered with hyperkalemia and hyponatremia. Further testing showed increased levels of 17-hydroxyprogesterone, which is increased in the classic form of CAH, leading the diagnosis towards 21-hydroxylase deficiency. Next slide, please. So this is the chromosomal analysis. What is more important here is actually the first, after the baby of Ranjana Agrawal, in the second line, they thought that the patient was female at first. And then they found in the karyotyping for it to be XY. So this shows the ambiguous genitalia that was seen in this child. Next slide, please. Here in the USG report, you can see in the second picture that there was ectopic or undescended testis and there was absence of uterus and ovaries. What is more important here is that usually in CAH, there is hyperplasia of adrenal gland, which is to be expected because there's increase in ACTH secondary to deficiency of cortisol and aldosterone. But here the adrenal glands are normal. Next slide, please. I couldn't get a picture of the ambiguous genitalia and the mother was reluctant to do so, which highlights the social and the psychological importance of this case in our Indian society. Okay, my time is up.
Yes, thank you for that.
Thank you.
Sir and ma'am, any questions?
Yes, Darshini, I just have one comment.
Yes,
only one comment and no questions. That next time when you use a patient file, please blacken out the identification features of the patient file before presenting it on a platform which is getting recorded.
Right.
You know, it's an ethical violation. So just put a black mark over the name or identifying features, the hospital where the child is. If you're talking about so much of reluctance from the mother, these are the points that we should all remember. Yes, otherwise, a very, very interesting case.
Sorry, ma'am, that was my mistake. I'll avoid it definitely and keep it in mind in my futures.
Yes, we all learn from our mistakes.
Yes, ma'am. Thank you and sorry.
Yeah, how can you explain the normal adrenal gland in this patient? You expected hyperplasia, right?
So, yes, sir. Certainly, it is that makes this case different from the existing literature that is present. Maybe it could be because that the baby was has a milder form of the disease, even though there is aldosterone and there is deficiency of that we suspect, and I feel that there has been an electrolyte imbalance. In my opinion, I feel that when the kid grows up and when this is just an 8-month-old, so as the kid progresses and grows in life, if the supplementation of aldosterone and cortisol has not been given and the kid did not get any treatment, then bilateral adrenal hyperplasia may be seen. Additionally, this USG, the USG that was done very earlier in the patient. It was so if we do a recent, if there was a recent USG that was done, that could have shown a bilateral adrenal hyperplasia.
What are the clinical symptoms of hyperkalemia and hyponatremia in children?
So firstly, there would be seizures, as this case says. There is, because of the severe electrolyte imbalance, first thing can be seen is seizures. Secondly, there can be severe arrhythmia that can be seen in the kids because there is such a electrolyte imbalance, so the membrane stability is lost. So seizures along with arrhythmias, severe arrhythmias can be seen, which can actually pose a threat to the child's health in the future. So I think that we should be really, as students, we should be well versed with such diseases so that we improve the prognosis and catch the diseases earlier only.
The child had ambiguous genitalia. What advice have you given the parents?
Firstly, so we counseled them about this condition thoroughly. Secondly, we told them that in the future, if exogenous supplementation is given, that there can be a possibility that there can be a possibility. Firstly, there's definitely this ambiguous genitalia is something that is going to stay for a long time. But with treatment, we told them that the prognosis of the child will get better. Secondly, we also referred them to the psychiatry department of our institute, and we told them, counsel them about the we counsel them about this, how this is going to stay, and it's not something that is abnormal, and the normal quality of life will be fine, apart from the psychological impact that this case on them. We also counsel them about the part of prenatal androgen exposure, because it is possible there was no family history in this patient, so it's possible that there was any androgen history, androgen exposure during the pregnancy of the woman, of the patient, and the parents were very young patients, so we counsel them about that as well. So in the future pregnancies, they keep this in mind, that they're very careful with what medications they take during the pregnancy.
Thank you.
That was what we did, sir. Thank you.
Good presentation. Thank you.
Thank you, sir.
Thank you so much for that. Can we move on to the next presentation, please? Ananya?
Yeah, I'm here.
Yes, whenever you're ready.
So I'll start. Good evening, everyone. I'm Ananya, a second-year student. Next slide, please. Next slide, please. Yeah, and I'll be presenting a case of locked-in syndrome, which is a rare neurological manifestation. Could you go back to the previous slide, please? No, the third slide, please. Thank you. So 29-year-old female in her third trimester presented with history of headache since 2 days, which was followed by a seizure. Patient was non-compliant to her hypertensive treatment for 1 week prior to presentation, and she was shifted to a tertiary care hospital due to a prolonged post-ictal state. Next slide, please. Upon presentation, her GC score was 3. She was unconscious. All the brainstem reflexes were absent. There's quadriplegia and no response to deep pain. The MRI revealed a pontine bleed along with perilesional edema. Also, multiple areas of hyperintensities, as can be seen on the MRI, were there. All of this was in favor of PRES, which is a very common finding in eclampsia. And the etiology of this was confirmed to be uncontrolled hypertension. Next slide, please. So management consisted of anti-epileptics and antihypertensives. And gradually, as the patient was weaned off of ventilation and sedation, we noticed eye bobbing movements, which are classical for pontine bleed. So these movements consist of vertical nystagmus, with the fast component being downward, as depicted in the diagram, and the slow component being upward. Next slide, please. Next slide. So apart from that, daily neurological monitoring showed very poor recovery. And in the end, it was observed that the patient was able to maintain blood pressure, oxygenation, urine output, and had normal digestive and cardiac functions, but she was still quadriplegic and was responding meaningfully to verbal commands with only eye movements. And thus, it was diagnosed as a case of classical locked-in syndrome. Next slide, please. Next slide, please. So such a state can be very difficult to diagnose, firstly, because there are so few documented cases, and secondly, because it closely resembles other states like unconsciousness. Studies have also suggested that the mean diagnosis time is 2.5 months, during which the patient can be considered to be unconscious. Hence, it is very essential to aid these cases to aid in faster diagnosis. Next slide, please. One point that I would like to emphasize is that the autonomy of the patients must be preserved, because these patients have intact cognition and mental faculties. Hence, medical professionals must enable these patients to communicate using eye-blinking movements, which are preserved in most cases. And thus, they can be involved in the decision-making process regarding their own healthcare. And while formulating the treatment plan, we must also keep in mind that the quality of life in such patients, according to self-reported studies, is meaningful, as contrary to what we can assume that it is not worth living. So that's it. Thank you.
Thank you so much. Questions? Certain, ma'am.
Yeah, Ananya, that was really a nice presentation.
Thank
and
you.
A very short and crisp presentation. And you've talked about the 4 pillars of ethics and euthanasia, but Just
Yes.
going off the track, do you think this should be legalized in our country?
Euthanasia.
Do not resuscitate, or euthanasia. Should it be legalized in our country? I'm asking your frank opinion.
My personal opinion would be that it can be with the correct laws which are put in practice, such as in cases like where the patient's own mental faculties, their cognition, their consciousness is intact. Only in such cases they should be allowed to take decisions regarding their own healthcare, because when we talk about ethics and when we talk about autonomy, it has to be applicable to whatever the patient's decision is. We are no one to judge what is their right decision and what's the wrong decision. So if their cognition is intact, then that decision must be up to them. So I am for it.
And when you in this condition,
Yes,
you
ma'am.
found that the patient has a classical locked-in syndrome. What can be the other reasons for such a condition? What
As in
what
the
all can
etiologies?
what all can be the etiology for this situation, this
The
presentation?
So the most common etiology is vascular, which is the same in this case. So there was a basilar artery hemorrhage which caused an hemorrhagic stroke. Other causes can be traumatic injury to the brain, or it can be rarely seen in cases of due to infections or something. But the most common are vascular or traumatic etiologies.
All right. Thank you.
Thank you, ma'am.
So,
Yeah, hi.
Hello,
You
sir.
have mentioned one of the differential diagnoses as GBS.
Yes,
Which
sir.
type of GBS are you talking about?
Sometimes in GBS, the for a short period of time, the symptoms might mimic that of LIS. That is why I have mentioned.
Which variant are you talking about?
Sorry, sir.
Which variant of GB are you talking about?
I'm sorry, sir. I'm not quite clear on which variant it is.
Okay. Do you know what is 1.5 syndrome?
So in 1.5 syndrome, it is because of the horizontal eye movements are preserved as well, according to what I have read. But in LIS, it is a more severe form of that. So only the vertical eye movements are preserved.
So where is the lesion in both the cases?
So, sir, in LIS, the lesion is in the ventral pons, and the area that controls the vertical eye movements is located in the midbrain. It's part of the medial longitudinal fasciculus of the midbrain, and that is why the vertical eye movements are preserved and eye bobbing can be seen.
Okay, right. Thank you.
Thank you, sir.
Thank you so much for the presentation. Can we have the next presentation, please? Anusha, are you here with us?
Yeah, can you hear me now?
Yes, thank you. We can hear you. Whenever you're ready.
Yeah, is my video coming?
Yes, yes.
Okay. Okay. So good evening, everyone. I'm Anusha Jha, and today I'm going to present a rare case of malabsorption syndrome with common variable immunodeficiency and Crohn's colitis. Next slide. So introduction, what is common variable immunodeficiency? So this is an immunodeficiency, which is a disorder of the adaptive immune system, and it's the second most common primary immunodeficiency which exists right now. And there is an increased susceptibility to infectious and inflammatory conditions with a person who has this disorder. And since the GI tract is the biggest lymphoid organ in the body, so an immunodeficiency, a person with such an immunodeficiency can develop a variety of gastrointestinal pathologies with non-specific manifestations which may be difficult to treat. Next. So here we describe the following case. Next. So this is the description of the case. Coming to the chief complaint. So a 35-year-old male was referred from the medicine department to the gastroenterology department of KMC Manipal, and his chief complaint was chronic diarrhea since 6 months. Next. History. So history of presenting illness, he had chronic diarrhea since 6 months, which consisted of loose stools multiple times a day with specks of mucus, and it was associated with loss of weight and appetite. His past medical history was significant for megaloblastic anemia since 2 years, and he had no other comorbidities. Next. On examination, pallor was present and he appeared malnourished. However, his general examination was normal, his vitals were stable, and his systemic examination was also normal. Next. So at this stage, the clinical impression, just on the basis of his clinical features, an examination was malabsorption syndrome, either due to an inflammatory bowel disease or tuberculosis. Next. And thus various investigations were done to rule out differentials and come to a definitive diagnosis. Next. So the following investigations were done. Firstly, all these routine investigations were done, such as a CBC, ESR, total protein, RFT, LFT. So CBC obviously showed macrocytic anemia since he had a history of B12 deficiency. Total protein, albumin and globulin levels all were reduced, and this was suggestive of hyperproteinemia, which was correlated with the malabsorption syndrome. Other investigations were normal. Stool routine was done to check for parasitosis, such as giardiasis, and that was negative. MAN2 test done for tuberculosis was also negative. Next. Coming to the specific investigations, now an ultrasound abdomen showed fluid-filled jejunal loops with mesenteric nodes, and these jejunal loops are filled with fluid, as the hypoproteinemia would have caused ascites and bowel edema. Next. And a serum immunoglobulin profile was done, and it showed the following findings. Next. So here we can clearly see that Ig and IgG levels were markedly reduced, and IgM level was on the lower side of the normal range. So these features were suggestive of common variable immunodeficiency. Next. Next. Yeah. Next. Next. Yeah, that's it. No. Previous one. Just the picture. Yeah. So
the time is over. Anusha, the time is over.
Okay. Can I just run through the slides? I mean, we have the. Okay. I'll just describe it. So we have.
We can just run through the slides. We can just run through the slides once. Shrutika, can you just run through the slides once? Yeah.
So upper and lower GI endoscopy was done, and you could see features of common variable immunodeficiency and Crohn's disease both. And here the histopathology, ileal biopsy, and colonic biopsies were done. So therefore, this was diagnosed. And he was put on corticosteroid and immunosuppressant treatment. These were my differentials: infectious, non-inflammatory, inflammatory causes, as well as malignancy. Discussion. So basically, CVID and Crohn's disease was coexisting in this patient. This is the limitations of a case study, obviously. These are my references. Thank you.
Thank you so much. Sir and ma'am, question, please.
Yeah, Anusha, an interesting one, you've covered all the differentials also. But if the stool microscopy is negative for Giardia, what is the other test that you can do? Can you do it?
Ma'am, we can do staining for fat, because there is fat malabsorption in Giardiasis, right? So you can stain for fat and see whether there is fat in the stool, and we can see whether there is fat malabsorption. That is one of the tests, right?
Anything else?
We can do a stool smear just to check whether the parasite is seen on the...
If you're looking for any organism, what is likely to be present? If you can't see the organism, what is more likely to be present, which you can detect using some other procedure?
Oh, the immunoglobulin against IgG or IgM immunoglobulins.
What gives rise to the immunoglobulin? Can you detect the antigen in stool?
Okay, antigen detection, yes.
Okay, sir, please.
Yes, sir.
Yeah, hi Anusha. In your general physical examination, in your general physical examination, if you had clubbing, how would it help you?
Sir, if we had clubbing in the general physical examination, it would point more towards malignancy. Like, because he had chronic diarrhea, loss of appetite, and weight loss, and he was malnourished. So
what are the GI causes for clubbing?
GI causes for clubbing. Yeah, so like off the top of my head, I remember the pulmonary causes like bronchiectasis and lung cancer.
I want GI causes. Your case is a GI case. What are the GI causes of clubbing?
I mean, I said that clubbing could point towards malignancy, but clearly there are some other causes which is not striking me right now.
It is something
Yeah.
related to your case. Anyway, what about stools? What did you find in stools?
Actually we tested for infectious causes also. So no
in
infection.
this case, what was your finding in stools?
So stool was unremarkable because he had a immunodeficiency.
There was absolutely no blood, occult blood, anything like that.
No, sir, no, because he had Crohn's disease coexisting with.
Despite there being ulcerations in the gut, are you not surprised?
Yes, yes, sir. As in, no, on the colonoscopy, yes, mucosal ulcerations and that was seen on colonoscopy. Yes, but as in, if you talk about specific stool microscopic findings per se, like infectious causes were not seen. Like if you talk about
microbiological findings, madam has asked you. I'm just interested whether the patient had occult blood or any evidence of, because so much ulceration that would have easily pointed towards a gut pathology.
Okay. Yes, sir. Yes, sir.
How do you differentiate ulcerative colitis from Crohn's disease?
Sir, there are a variety of ways we can differentiate ulcerative colitis versus Crohn's disease. So first thing is Crohn's disease would mostly be is more in the ileum, whereas ulcerative colitis would be more starting towards the rectum and in the sigmoid colon. Then then the lesions on grossly the lesions seen in Crohn's disease would be cobblestone appearance, skip lesions would be there, and cobblestone appearance and transmural inflammation would be there. Whereas in ulcerative colitis, the lesions are superficial and there'll be backwash ileitis or backwash proctosigmoiditis, like superficial inflammation, and there will be continuous inflammation, not like cobblestoning. Then in Crohn's disease.
What is the age of your patient? What is the age of your patient?
Sir, 35-year-old male.
35. So what complications do you expect? Extra-intestinal complications in this patient?
Sir,
of Crohn's disease.
Sir, extra-intestinal complications of inflammatory bowel disease can be ankylosing spondylitis, uveitis, urethritis, stuff like all those extra-intestinal complications. Yes, sir.
Thank you.
Yes, sir. Thank you.
Thank you so much for the presentation, and thank you so much, Ajit, for the question. Can we move on to the next presentation, please? Okay. Janvi, do we have you here with us today?
Yes. Can you hear me?
Yes, we can hear you. We can start whenever you're ready.
Okay. Good evening. My name is Janvi Srinivas, and today I will be presenting a case about unicentric Castleman disease. Next slide, please. Next slide. Okay, so starting off with the introduction, unicentric Castleman disease is a group of rare disorders characterized by enlargement of a group of lymph nodes, specific microscopic changes to the lymph nodes, and a broad range of symptoms and laboratory findings. It is a subtype of Castleman disease, the other being the multicentric variety with the involvement of multiple groups of lymph nodes. Next slide. So in this case, a 56-year-old female presented with the following chief complaint of abdominal pain for the past 9 months. Next slide. Okay, so the history of the presenting illness, the abdominal pain was intermittent in onset. Duration was for the past 9 months. The site was the epigastric region. It was diffuse, non-radiating, and associated with history of nausea. Next slide. Next slide. Next slide. So the past history was all unremarkable, similar to the examination. General and per abdominal examination was both unremarkable. Next slide. So now moving on to the investigations, USG abdomen showed a retroperitoneal mass to the left of the midline with increased vascularity. CECT abdomen showed a well-defined isodense lesion in the pelvis. It was left to the midline and extended superiorly to the L5 and inferiorly to the S2 vertebral body. Next slide. Moving on to the PET-CT scan, which showed well-defined heterogeneously enhancing FDG avid lesions in the pelvis, left to the midline. The feeding artery was the left common iliac artery, and an aberrant artery was noted arising from the left lumbar artery and draping around the anterior aspect of the lesion. Next slide. So for management, a diagnostic laparoscopy was conducted, which showed an 8 into 10 centimeter friable mass in the retroperitoneal region of the left iliac fossa. Large tortuous feeder vessels from the left common iliac vein to the tumor were also seen. Next slide. So due to the limited access, a midline laparotomy was done. The tumor was dissected from the left iliac vessels and surrounding structures, and the tumor was sent for histopathological examination. Next slide. So during this examination, proliferated lymphoid follicles with hyaline vascular type of Castleman disease were found. The patient made an uneventful and complete recovery after the resection. Next slide. So the differential diagnosis possible in this case include lymphoma, metastatic adenopathy, infectious or inflammatory causes of adenopathy. Next slide. So Castleman disease is a very rare disorder, while the multicentric variety is associated with infection by a virus called human herpes virus 8. The cause of the unicentric disease is yet to be determined. People with Castleman disease also have an increased risk of developing cancers like lymphoma and Kaposi sarcoma. Next slide. The average age of people diagnosed with unicentric Castleman disease is 35. It also shows a significant male predilection. The incidence of Castleman disease has increased in the recent times because of its association with HIV and human herpes virus.
The time is up. Thank you so
Okay.
much for that.
Thank you.
Sir and ma'am, questions, please.
Yeah, Janvi, very interesting case, but and a very common complaint of abdominal mass and abdominal lump and abdominal pain. Can you tell me one thing? You said there are multiple, DDs which you mentioned in your presentation.
Yes,
but could you just tell from the history, from the symptoms, and from the history, and from the investigations that were done, how are these ruled out one by one?
Ma'am, I feel like infections and inflammatory causes can also cause enlarged lymph nodes, which was what was seen in this case. But that would also include other causes like inflammation, redness, maybe warmth around the lesion. And the main method to diagnose Castleman disease is only through histopathological examination. So it's only through biopsy, and in this case, the patient was opened up and the lesion was tested and removed immediately. So that's
Okay,
how
why did you include tubercular lymphadenopathy in this condition as DD?
Yes, ma'am, that can also be a possibility, but since again a histopathological examination should have shown maybe granulomas or something like that, which was not there in this case. Thank you, ma'am.
Which patient, suppose a patient is coming to you in the casualty, which patient would you suspect Castleman's disease?
So Castleman disease is usually seen in patients who have a defect in their immune system, which is why it's commonly seen with HIV. So maybe patients who have maybe pressure symptoms of like around the lymph nodes. Like for example, here it was abdominal pain. Some patients with Castleman disease around the abdominal region also show bowel obstruction and things like that. So with symptoms like that accompanied with immunodeficient history, that would maybe point to Castleman disease.
What about Kaposi sarcoma? Which are the common sites for Kaposi sarcoma?
So Kaposi sarcoma, as far as I have read, it presents with skin lesions over the body, mainly over the chest and back region.
Then why did you bring it as a differential diagnosis for your case?
No, sir, I've not included it as a differential diagnosis. Kaposi sarcoma is a possible complication of the case because the disease is often associated with HHV8 virus, which also leads. It's also a risk factor for Kaposi sarcoma.
Could a cluster of differentiation staining help you?
Sorry, sir. No.
CD typing, could it have helped you?
So I'm not too sure about that. So the what I've read is that the
Right.
Yes. Sir.
It's a good presentation.
Thank you, sir.
Thank you.
Oh, thank you so much. Can we have the next presentation, please? Okay. Ria, are you here with us?
Hello, am I audible?
Yes, you're audible.
Can I
Whenever
request that, one second, can I request that I present my own slides, as my slides have too many visual effects that I won't be able to orally coordinate?
Unfortunately, due to technical issues, we cannot
Then
allow
can
that,
I
and it will not be
request,
fair to the other participants since all of them for everyone we have shared the screen. So we will
can
be
I
going ahead
request
with
an
this.
extra half a minute in further during the visual effects because of the time loss?
We will see. We cannot allow that as well. So please start with your presentation.
Yeah. A very good evening to everyone present here. My name is Ria, and I'm going to be presenting on exit procedure in a case of lymphangioma. Next, fetal lymphangiomas are congenital benign cystic lesions. Next, the patient is a 26-year-old female which presented to the department. Her first pregnancy in 2018 led to a spontaneous miscarriage, and her current pregnancy, which is a second pregnancy, she presented to the department at 37 weeks and 5 days of gestation after being referred here. Next, her past and personal history were insignificant. And next, so were her general and systemic examination findings. Next, going on to her investigations and diagnosis. Next, these were her past investigations, of which next, her target scan revealed a multiseptate avascular cystic lesion, which was performed at 22 weeks and 1 day of gestation, which was very characteristic of a fetal lymphangioma. Next, when she presented to the department at 37 weeks and 5 days of gestation, an ultrasound was taken, which showed normal growth, activity, liquor, and fetal heart rate. Next, as seen in these images. Next, an ultrasound was also they also confirmed the presence of the multiseptate cystic lesion, and in color Doppler it showed no vascularity. So this is again confirmatory of the lymphangioma. Next, an MRI was performed on the same day. Can you please keep clicking for the effects? And on the same day, and it showed a T2 hyperintense image, which is seen here. It extends up to the T3 region, and it also seen to encapsulate the internal carotid artery and the internal jugular vein on the left side, and it also showed tracheal compression. Next. So the diagnosis of fetal hemangioma with a airway compression was made. Next. So the proposed management was to do an ultrasound, a fetal MRI, and deliver at 38 weeks of gestation. But next, the patient went into labor the same day, and an emergency exit strategy had to be planned and executed the same night. And the child was delivered at approximately 12:30 a.m. the same night. Next. So the child was delivered and put on ventilation and weaned off it. Next. So fetal neck tumors include goiters, teratomas, lymphangiomas, hemangiomas, neuroblastomas, etc. Next. So the lymphangioma, which is my current case, is a benign tumor of the lymphatic system. It can be uni or multiseptate. It is always avascular and mostly cystic in nature. It usually presents in the neck and the axilla region and is associated with several obstetric complications. Next. So the treatment is usually an exit procedure in case of complications, which is rarely performed because of its maternal mortality rate. Next. So can you please click again? Next. Yeah. So an exit procedure is an ex utero intrapartum treatment in which the fetus, in case of airway compromise, is partly delivered while on placental circulation. Its airway is secured and completely, and then it is completely delivered. Yeah. Next, can you run through the slides, please?
Please run through the slide, please, Shrutika.
I'd like to conclude alone by mentioning that according to the MTP Act of 2021, termination of pregnancy is only permitted up to the gestational age of 24 weeks. Hence, early detection is essential. Thank you.
Thank you, Clay. Thank you so much for that. Saran ma'am, over to you.
Yeah, Ria, the very interesting case. And sometimes these kind of cases, this presented in utero, right? This was diagnosed in utero.
This was diagnosed in utero, ma'am, and the surgery performed is pretty interesting because this was the first time the surgery was performed in my city.
Okay, So the child was delivered, and then after that, the surgery was performed to relieve the
No, ma'am.
hemangioma.
No, ma'am. No, ma'am. So the child was partly delivered and kept on placental circulation till the airway could be secured by a group of ENT surgeons. And after the airway was secured, the child was completely delivered. So it is a partial delivery while the airway was being secured. So so this was done under both maternal and placental anesthesia with uterine relaxants, which is quite unusual as compared to a cesarean section, because uterine relaxation can lead to severe maternal hemorrhage and lead to maternal death. So that's why the procedure is not preferred in normal cases.
Right. Okay. Thank you. So,
Yeah. You said the best thing would be to have an early diagnose, right?
Yes, sir.
How do you diagnose it early? Because there's no specific karyotyping features for this, right?
No, sir. It has a specific karyotyping feature, but in 69% of the cases, we see abnormalities in the 13th and the 21st chromosome, in which can include deletions of the long arm or trisomies. And in ultrasonographic,
this was not done in your case.
It was done in my case, sir. I've mentioned it in my slides. Can I please go back?
Yeah.
The karyotype. Can we please go back? It's fourth to the fifth slide. Back. Yeah, next.
Yeah, here only.
Yeah. Yes, next slide. Yeah, this the fish, the karyotyping, and the sex chromosomes are also normal. But in my case, can we go to the discussion?
So what are
please?
the abnormalities that you see when a patient would appear to have hemangioma? How do you diagnose it early?
The symptoms and the signs, or the radiological and the
No, how do you diagnose it early? I would like to know.
So early diagnosis would be during. Even in our case, it was diagnosed early. It was diagnosed in the 11th, and during the target scan itself, which was performed in the second trimester. So they could have still performed. Because then fetal airway compromise was also seen, so an abortion was still possible at that stage. But because the patient was referred to us only at 35 weeks and 7 days and 37 weeks and 5 days of gestation, we couldn't do much and had to go for an emergency exit procedure.
What would be the prognosis of this child?
So the prognosis is quite good because the airway, the fetal airway had been secured during the procedure. But in case we'd gone for a normal delivery,
why would you advise? No. If the prognosis of the child is good, if you do a proper delivery.
No, sir. In case we'd done a proper delivery, a normal or a cesarean section, that would have led to fetal airway distress during delivery, and it would have led to fetal mortality. The survival of the child was almost negligent in case of normal delivery. At the exit procedure, the fetal survival was high.
So you have done an exit. You have planned an exit procedure.
Yes, sir.
Right? Would you still advise ethically that this baby be terminated early?
Yes, sir, because exit procedures are not commonly performed in India, and it is also a fetal surgery. So there are not many hospitals around the country have fetal surgeons. So it would be unethical to do it in those conditions where we neither have the technology nor the equipment nor the expertise to perform it.
Okay, thank you.
Thank you, sir.
Kalpita, can we move to the next one, please?
Yeah. Shrutika, can you move on to the last presentation, please? Okay, Prastiti, are you here with us?
Yeah, hi, I'm here.
Yeah.
Am I audible?
Yeah. Yes, whenever ready.
Okay, thank you. Hello, everyone. Good evening to one and all present over here. Myself, Prasuti Verma. I'm here to present a case on an eccentric association of congenital adrenal hyperplasia with inspissated bile syndrome and polycystic kidney disease, an abnormal presentation of fairly rare disease. Next slide. Next. The introduction. The congenital adrenal hyperplasia is previous slide. The congenital adrenal hyperplasia comprises of a group of autosomal recessive disorders resulting from deficient adrenal corticosteroids due to mutation or deletion of genes responsible for the biosynthesis. Rarely, severe cases result in adrenal insufficiency in infancy with or without virilization and salt wasting. Next. A baby was born of a non-consanguineous marriage, was delivered at a private hospital and presented at our institute on fourth day of life with chief complaint of yellowish discoloration of skin up to palms and soles. Next slide. There was no significant past history with mother except for that the previous child had CFTR gene positive who expired in infancy at 4 months. And there were no antenatal complications and the mother's blood group of was O negative and that of the fetus was O positive. That resulted in the ISO immunization and hence for the blood transfusion which will be discussed subsequently. Next slide. The baby was delivered full term at a private hospital via vacuum assisted vaginal delivery at 38 weeks of gestational age. No resuscitative measures were performed. ABGAR scores of 8 on 10 at 1 minute and 9 on 10 at 5 minutes were recorded. Oligohydramnios was present. Next slide. General examination was normal, vitals were normal. The only markable features were skin was hyperpigmentation and icterus was present up to palms and soles. Next slide. Systemic examination was also normal. Next slide. Lab investigations revealed that complete blood count was normal. Serum electrolytes on admission were normal, but on the 12th day of life, the fetus started with the baby started with severe salt wasting. Thyroid profile was normal. Total direct and indirect bilirubin were raised before the transfusion and started decreasing after the blood transfusion. USG abdomen revealed testes were absent. Presence of uterus and ovaries with left polycystic dysplastic region. MRI revealed bilateral enlarged adrenal gland at cerebriform appearance. Uterus and ovaries are present. Testes were absent. Karyotyping revealed 46XX karyotype pointing towards disorder of sex development and hence 17 serum 17 OHP, ACTH and renin levels were tested which all came to be increased. Next slide. Next slide. Next slide. Differentials were kept for the congenital adrenal hyperplasia for 3 enzyme defects, but the 3 beta hydroxylase and 11 beta hydroxylase were secluded because of both the renin and 17 OHP levels were increased. Hence, it was concluded that the diagnosis was made for 21 hydroxylase deficient congenital adrenal hyperplasia syndrome. Next slide. Next slide. Next slide. For treatment, exchange transfusion for done for RH isoimmunization. For salt wasting, treatment with fluid resuscitation, hydrocortisone and fluorocortisone tablet and sodium was given. Next slide.
Prestige time's up.
Okay, can I go to the conclusion? Just the conclusion.
We'll just run through the slides once.
Okay.
Okay.
These are the photos of the patient.
Run, ma'am, over to you.
Okay.
Prasuti, again, a very interesting case. What I would like to know is that clinically, how do you suspect these kind of congenital, karyotyping and all these things may not be available in smaller cities and smaller areas. So in those situations, how do you diagnose these kind of conditions? What is the clinical picture which points towards this kind of, any kind of these congenital disorders?
Yes, ma'am. Since it was a disorder of sexual development and on a physical examination, the patient came with that we have a boy, and the scrotal sac were empty, and there was enlarged clitoromegaly was reported, and the patient came from the private hospital carrying a report where they said there was undescended testes, and there was unexplained electrolyte imbalance and unexplained icterus. So for that, we went for MRI to check, MRI and ultrasonography to check for testes and ovaries situation, and where we found that testes were not there only, ovaries are there, and for which we proceeded towards karyotype to find out the karyotype. And after we found that the karyotype is 46XX, we went with and since till then
another thing I want to ask you is what are the differentials when you see a child who's got icterus right up to palms and soles? What does it indicate and what are the DDs which come to your mind besides this case?
Jaundice, and the first thing that comes is jaundice.
Diagnosis? Jaundice is a diagnosis, sign, symptom, or disease?
It's a symptom. It's a symptom.
So what are the DDs? Okay, sir. Over to you.
A nice case. The baby also had polycystic kidney, right?
Yeah.
So what other organs can be involved when you have a cystic kidney?
They may be reported hepatosplenomegaly, and since the adrenals were already
I'm asking
affected, there
where
are
else can the cyst be present?
um, ovaries.
What did you do a scan of the liver?
Sir, we did MRI, and like the liver and the rest of the organs were normal.
Hello?
Hello?
Yeah.
Hello? We did an
Yeah.
MRI, and the other organs in the abdomen were normal, including liver, spleen, everything was normal. We did an MRI.
What advice would you give the parents of this child?
We can ask them for a follow-up and a surgical opinion from a surgeon, from a plastic surgeon, for gender reassignment surgery and vaginoplasty and reconstruction surgery in future, and with adequate hormonal control and adequate treatment, we can manage the fertility issues as well. So we need for till the time that the child hits puberty, we need to take care that the child is properly maintained on the drugs, and electrolytes and BP is checked frequently, and that
Will you
the
maintain
child
the
is
electrolytes of this child?
by administering fluorocortisone and hydrocortisone.
Okay, thank you.
Thank you.
Thank you so much. With that, we come to the end of our competition, the final round of the competition. I would like to hand over the floor to Dr. Sonal Saxena ma'am and Dr. Madhav Prabhu sir to give their final reflections and to have 2 words of wisdom from them.
Yes, students, it was a very, very interesting presentation. Believe me, it's a treat to see all young budding doctors, working so hard on, and you have actually utilized the online mode very, very well and adjusted very, very well. It took us, I think Dr. Madhav will also agree with me, it took us a lot of time to switch on to the online mode because, and I still miss those interactions. We've still not yet started the physical whole batch classes. We are still continuing that on an online platform because we can't have 270 students in one LT, and I really miss one-to-one interaction with the students. So it was very, very interesting. All the cases were very interesting. And I have my 2 points on this would be that, first of all, when you are working on any case, look at the signs and symptoms in such a manner that you are arriving at a diagnosis. When you have a certain, why I was asking DDs in every case was that those DDs you should be able to strike off with your signs and symptoms, because that is what you're going to see in the ward. Very often you will not have access to sophisticated tests. Even in your examinations, you will not have access to any investigations. So you can only recommend what you will investigate. So as a point of primary care physician, which you are all going to become after MBBS, try stick to the basics. I think nowadays the students, whether it is postgraduate or undergraduates, are so hi-fi in their approach. They straight away talk of MRI. And here I'll tell you one little anecdote from my teacher who used to tell us at that time the CT scan and MRIs were coming when I was an intern. And he used to say, what will you do for a head injury patient has come to an emergency? He was a surgery person, and everybody would come up CT, MRI, because they were just coming in at that time. And he used to say, okay, but I would like to put in an IV first. And that moment we would do, oh God, because these are the basics which are going to save somebody's life, and these are the basics which should stay with you all your life. And Dr. Madhav, it was nice meeting you here. Sometimes when I'm in Belgavi, I'll come and see you also. And if you are in Delhi, you're most welcome and come and see me in Maulana Azad. This platform has given us an opportunity to meet. But I would love to meet you at any point of time in Belgavi or in Delhi, whenever you are. And all of you students, I think Shrutika is nearest to me. So you're most welcome anytime to come and chat, to come and discuss anything that you would ever want. So with that, these are my closing words. Thank you so much. Over to you, sir.
It was great knowing you, ma'am, and perhaps we are going to meet in Arpita's convocation. So, actually, you spoke all that I wanted to speak. And when we are, as clinicians, looking at cases, we are more interested in the approach of the patient. That's what I had told yesterday also. Because we know that finally you are going to do some investigations, MRI, echo, and all those things. We can solve all the things. But as a clinician, you have to have the right approach. And that is developed when you start seeing more and more cases. So every time you see a new case, for example, let me tell you, there is a single disease which could have many presentations. And the diagnosis could be same, but then there are different presentations. So, for example, that GB syndrome, that one of the differential diagnosis was there. I wanted to see whether the variants of GB, Miller-Fisher variant or something is seen where you are this thing. So you need to know clinically, you need to have a lot of knowledge about every case, the different presentations, and clinically diagnose a case. And that is possible only if you have a good approach. Secondly, when we pick rare cases, this is to the organizers. We rarely see rare cases. I mean, we see maybe once or twice in a lifetime. But when you want to test the approach of a student, we need to give them good common cases also. And we need to find out how they built a diagnose, and what Madam was insisting on, how they build a differential diagnose. That is very important in clinical. I think we had teachers who had similar this thing. They used to always tell us that you don't go for the investigations. You have to form an approach to diagnose it clinically. And that's what we insist also. Because otherwise, you just go for an MRI CT and you have the diagnosis in hand. But if you have that approach, that is what medical thrill is about. You have to diagnose the case, you have to crack the case, and then confirm it with investigations. That's very important when you're doing clinical case presentations. Also, the focus should not be too much on investigations, because we are going into a field now. If you see, most of the cases had a flurry of investigations, some of which were very unnecessary. So when you have a approach, when you know that you're going to pinpoint this case to this system, you will be very conservative in your investigations. This is very important for you when you become clinicians, because tomorrow the patients will be all educated by Google, and they will come and ask us why you have done this, why you have done that. So you have to be very discreet when you form a diagnose and when you go for the investigations. I think next time we should have more stress on how the student approaches the case and how he arrived at the diagnosis, rather than the complicated procedure, which would be a specialty option. Thank you.
Thank you so much, sir. Thank you so much, ma'am. With that, I would like to hand it over to Dr. Molly. She is currently the president of Medical Student Association of India. Molly, over to you.
Hello, everyone. A very, very, very good evening to all the participants, to all the judges, to our SCOME national team who's present here today. Firstly, I would like to congratulate all the participants who presented their cases so beautifully, throughout in the given time, and keeping in mind all the required points. And I'm sure that it's not easy to present a case in front of so many people. And kudos to all of you. A very, very, very big congratulations to all of you to present your cases and to take active inputs from our judges. A very big thank you to Dr. Sonal and Dr. Madhav. Thank you so much for your time to be present here today to help our participants to learn more, to grow more, and learn from their respective presentations. And we know that it's a lot of time, and we really, really appreciate you taking out the time to help us with this and to make this case presentation more impactful and the most impactful it can be. Apart from that, I would like to also thank the entire SCOME national team who's been working on the case presentations since so long, along with our Vice President for External Affairs, Salman Khan. And we also have our national officers on medical education, Arpita, Saxena, and Prabhacha on the meeting today, who've been constantly working on the case presentations and reviewing and coordinating with the judges to make today's event successful. At the end, we know that there are going to be winners, and I'm sure that in each competition you do get to hear this, but there's a reason that it's it's always mentioned at every competition, that at the end of the day, it's important that you took the time out, you actively took part in this initiative to present your cases, because every little experience is only going to help you in refining your skills further. I'm sure that with the inputs which our judges today gave, you will make your presentations in the future better, and we hope we were able to help you with the same in any little way possible. With that, I think we can move. We'll wait for a bit for the results, and then I think we can call it a night.
I just want to compliment you guys, the Medical Students Association. You guys are really so enthusiastic and you're doing such great job. As students, we never had such opportunities. And I really want to compliment the entire team, the way you have arranged this thing, the way you have organized, the way you have put things together. This actually tells a lot about you guys and how the next generation is doing much better than us. And I feel you will be better doctors than us because you have so much exposure and you have put so many students and exposed them to so many new cases. I'm really proud of you guys. Well done, and keep doing these things.
Thank you so much, sir. That genuinely means a lot to us, and it is possible because we have support of we have your support, and you are helping us to become better each day, and that's what our ultimate goal. That's what our ultimate goal for all the medical students is, to make them better future healthcare professionals along this journey.
Great.
All the best. Keep up the good work. And I'll take your leave and I'll log out. It was nice meeting you all. Thank you so much.
Thank you so much, ma'am. I'm just 2 minutes and we'll be announcing the results. Give me 2 minutes. All right. I'm so sorry for the for the mysterious silence. And without any further ado, I'll be going ahead with the results for the case presentation competition today. I'll be starting with the third position, which has been which goes to Harsimran Kalsi. For her presentation on an unusual presentation of cutaneous tuberculosis, coexistence of lichen scrofulosaurum with extensive scrofuloderma. Harsimran, are you here? Congratulations. Perfect. I'm not sure if she's here on the call. Okay. With that, moving on to the second prize for the competition goes to Darshini Ramar for her case presentation on a case of congenital adrenal hyperplasia in an 8-month infant in Ahmedabad. Congratulations, Darshini.
Thank you so much. I realized today that I have a lot to improve on. And as ma'am said, I hope that this serves as an opportunity. I learned a lot of cases as well. Like today, it was such an interesting time. I hope that I'll also like learning as both of the judges said, I hope that I become a better clinician by just looking at the symptoms and making a differential diagnosis. And I'll definitely improve on mistakes. Thank you so much for this. Thank you.
Thank you so much again. With that, the first prize goes to Ria for her case presentation on exit procedure in a case of fetal lymphangioma. Congratulations, Ria. Are you here with us?
Yeah, am I audible?
Yes, we can hear you. Congratulations.
Thank you so much. Very grateful for your honor, and thank you so much for all the advice. I hope I'll improve on the next presentation. Thank you.
Thank you so much again. With that, congratulations to all the winners, and we'll be coordinating with you for the respective prizes by Kaplan. And a big congratulations to all the participants who took the time out to present their cases here, and to all our judges as well. Thank you so much again, and we wish that you have a good evening ahead. Thanks a lot.